Mesenchymal stem cell treatment for multiple sclerosis. Our standard disease-modifying therapies all work on the immune system, but is it possible to regenerate lost tissue using stem cells? I'll review what this treatment is, the evidence behind it, including the results of numerous randomized controlled trials, along with the potential risks. Remember what the Buddha said, the only real failure in life is to not try. So during embryonic development, the blastula undergoes a process called gastrulation and forms the gastrula, which has three cell lines, the ectoderm, mesoderm, and endoderm, which give rise to the tissues shown here. And mesenchymal stem cells are primarily derived from the mesoderm and give rise to these tissues, and you may notice immediately that the nervous system actually normally arises from the ectoderm, not the mesoderm. But it turns out that mesenchymal stem cells can differentiate into nervous tissue in specific conditions, and also ectodermal tissue forming stem cells has a lower potential to differentiate into specific tissues, and with implantation there's a risk of a type of tumor called a teratoma, so mesenchymal stem cells are thought to be preferred. The ability to get stem cells to home to specific tissues and differentiate into specific cell lines is a technical topic beyond the scope of this video. Mesenchymal stem cells can come from various sources, such as the bone marrow, and it's often from your own bone marrow, often autologous, but it's also possible to do an allogenic transplant from someone else's bone marrow. They can also come from the placenta, the umbilical cord, or the blood or associated tissues, embryos themselves, or various other tissues such as adipose or fat tissue, the peripheral blood, cartilage, or muscle, and there are specific technologies to cause partially differentiated cells to regress into mesenchymal stem cells. These cells have the potential to differentiate into many different cell lines, and thinking in terms of MS, they could differentiate into, say, oligodendrocyte precursor cells, which could turn into oligodendrocytes and potentially remyelinate injured tissue, or turn into different lost cells such as neurons or glial cells. They're also immunoprivileged, meaning they're not usually attacked by the native immune system, and so, as mentioned before, it's possible to do an allogenic transplant from a different and potentially younger, healthier recipient. These cells can secrete vesicles, which have components which could be absorbed by native cells, modifying their behavior. By the way, my name is Brandon Beaber. I make videos about MS every Wednesday, and please see the citations below, and also check out my book, Resilience in the Face of Multiple Sclerosis, completely free on Amazon. Now, the cells can be given in different ways. They can be given intravenously, as depicted on the left, and spread throughout the circulatory system, but they can also be given intrathecally. In other words, a lumbar puncture or spinal tap can be performed, and the cells can be injected directly into the subarachnoid space in the cerebrospinal fluid and spread throughout the spinal column and around the brain, and potentially be much closer to where you want them to be and maybe be more effective, though of course this is unpleasant and potentially carries additional risks to be discussed later. Now, it might be much more difficult than you think for these cells to get to the area of injury because of the blood-brain barrier. This is a natural barrier between the bloodstream and the central nervous system. You can see here a blood vessel depicted in the center, surrounded by the endothelial cells that form the wall of the blood vessel and the pericytes that form the blood-brain barrier and make it very difficult for things to enter. Of course, this is a natural protection against pathogens and perhaps certain toxins. Some small molecules, such as the chemotherapy drug methotrexate, can diffuse quite freely, but large raw stem cells have no known mechanism which would allow them to enter the central nervous system. There are other cells, such as lymphocytes, the B and T cells, which can enter past the blood-brain barrier using very specific targeted mechanisms, but again, for raw stem cells, it's unclear how they would get there. Now, in multiple sclerosis specifically, it might be a little bit different because there's evidence in MS that the blood-brain barrier is damaged, which may allow cells and potentially other things to get into the nervous system. Here's a quote from an article based on animal studies, and the author says mesenchymal stem cells go mostly in the lungs, but also in the spleen, liver, bone marrow, thymus, kidney, skin, and to tumors. These sites of mesenchymal stem cell engraftment do not appear significantly different between healthy animals and disease models in most studies. Of course, again, it could be different in MS because of that injury to the blood-brain barrier. The same challenge exists for an intrathecal injection. This is an electron micrograph of the meninges. Here is the brain in the lower left, and here are the meninges, the coverings of the brain. This is the very thick dura, though with an intrathecal injection, it's injected into the subarachnoid space. This is just a random blood vessel, but there's still two layers between you and the actual brain, the arachnoid trabecula and the pia mater, the latter of which is attached directly to the brain. And if you zoom in closely, this pia mater is an absolute wall, and to a stem cell would appear completely unassailable. However, this animal study on rats used to study stem cells in stroke. These rats had an intentional middle cerebral artery occlusion, found that the cells did get to the site of injury, and this was true regardless of the route, given intravenously into the ventricles, and the ventricles are contiguous with the intrathecal space I showed earlier, and even directly in the brain. It didn't matter, the cells got to the infarcted region. And they were able to increase penetration to the site of injury by making these cells express certain antigens such as nestin and double cortin. And another study found that 2.4% of intrathecally injected stem cells entered the rat's brain, so the penetration may be low, but if you give enough cells, some may get there. And you may have other skepticisms as well. Hey, the brain and spine are large structures. How would the stem cells even get to the site of injury, and what would they do there anyway? Why would they remyelinate rather than regrow cartilage, for example? But there may be other mechanisms of action other than regeneration and remyelination. There's some evidence that stem cells have effects on the immune system. For instance, they may increase interleukin-10, an anti-inflammatory cytokine that's actually been associated with the use of beta interferons, drugs used to treat multiple sclerosis, and they may reduce pro-inflammatory cytokines such as TNF-alpha, interleukin-6, IL-17, and CCL2. They also increase matrix metalloproteinase 9, which may be involved in remodeling damaged tissues, and with the release of those vesicles that are absorbed by native cells, they may regulate local tissue homeostasis and somehow prevent indirect injury. One other thing I'd like to add for clarification is that mesenchymal stem cell treatments are completely different from hematopoietic stem cell transplant, or HSCT. In HSCT, it's actually not a stem cell treatment. Stem cells are only used to help people recover from the actual treatment, which is powerful chemotherapy drugs which wipe out the immune system, known as the conditioning regimen. Some examples of drug used would be cyclophosphamide, anti-thymocyte globulin, and the multi-drug chemotherapy regimen BEAM. And it's actually these drugs that are deriving the benefit of HSCT. And HSCT is a proven treatment of MS. It's well established to be effective, though of course it does carry significant risk, and it has nothing to do with stem cell treatment or mesenchymal stem cells. I have a separate video on this topic, HSCT, in the notes below. And let's see how mesenchymal stem cells performed in clinical trials. Now, I'm going to refer to this scale called EDSS, or Expanded Disability Status Scale, used to measure disability in MS research. It's a 0 to 10 scale. 0 is no disability. 3 to 4 could be considered moderate disability. At EDSS 6, a cane is needed to walk 100 meters. At EDSS 6.5, a walker is required. And at EDSS 7, a wheelchair is required for all but short distances. We'll start with this small phase 1 pilot trial. This is an open label trial in Iran with only 5 participants, not a randomized trial. Everyone knew they were getting the treatment. They were not blinded, no control group, and they used placenta-derived mesenchymal stem cells. They gave 3 million cells per kilogram of body weight intravenously, and this was done on people with secondary progressive multiple sclerosis, and they did well. Here you can see the EDSS scale on the y-axis, and all of them, 5 out of 5, had improvements. You can see this participant in blue went from an EDSS of 7 using a wheelchair to 6 walking with a cane. This participant in light brown went from an EDSS of 6 walking with a cane to 4.5 able to walk 300 meters without assistance. So there are good results. Of course, there's a potential regression to the mean effect and placebo effect. Also, these participants did receive the drug rituximab, which has evidence in progressive multiple sclerosis, though it's not expected to reverse disability. It's expected to prevent relapses and reduce the risk of progression. It would be very unexpected for 5 out of 5 people taking this drug with progressive MS to get better. So this looks good, but again, not a randomized trial. In the same study, they looked at metrics of fatigue and cognitive function. So fatigue improved, depicted in blue here. They looked at a few measures of cognitive function, such as the PACE-AT, the Paced Auditory Serial Addition Test. This is a test where you hear a series of numbers like 5 and 3, and you have to add them together. So you would say 8, and then you hear the next number 9, and then you would add the last 2 together, you would say 12. It's a very difficult test, and there was a slight statistically significant improvement with a p-value of 0.04, but in a different measure of cognitive function, the symbol digit modalities test, where you have to decode different symbols, there was no improvement. They looked at their B lymphocyte counts, which went down during the study, and this is just due to the drug rituximab, so they were probably untreated prior to the study and started on treatment. This makes the results less believable in my opinion. They also looked at different cytokines, and they found some differences. They found that TNF-alpha went down, which is a pro-inflammatory cytokine. Interleukin-10 went up, which is an anti-inflammatory cytokine. Interleukin-6 went down, except for one patient, though this person coincidentally had COVID-19, which is known to raise IL-6 temporarily. Here's a different open-label trial. This one is done at 6 sites in the United States and 2 sites in Canada. They also used human placenta-derived cells, but they studied in both relapsing and progressive MS, and the results were much less consistent. Here we again see the EDSS score on the y-axis, but not everyone got better. Some stayed the same or even got worse. But let's move on to randomized trials with an actual control group. So this is the very well publicized MESEMS trial, mesenchymal stem cells for multiple sclerosis, a phase 2 trial, and they used intravenous autologous bone marrow-derived mesenchymal stem cells, a total of 144 participants aged 18 to 50 with either relapsing or progressive MS, 15 sites in 9 countries. Now, this study had a crossover design, so if you initially got randomized to placebo, you could later get the stem cells, but I'm just focusing on the first 24 weeks of the study where everyone is blinded and randomized, because after a crossover, it's hard to know what's happening. You could potentially benefit later on, now that you're getting placebo, if you previously got the stem cells, for example. And the primary outcome of the study was enhancing or gadolinium positive lesions, and there was absolutely no benefit to the treatment. But what about intrathecal stem cells? This is a randomized trial of intrathecal versus intravenous mesenchymal stem cells versus placebo. There were 48 people in the study, all with progressive MS, 16 getting intrathecal treatment, 16 getting intravenous treatment, and 16 getting placebo. And this is done at the Hadassah MS Center, and they had great results. Here you're looking at the change in EDSS. So the placebo is the dark circle, and they did 2 separate cycles, and you're looking at change from baseline, which is why the data look a little bit disjointed, because the first half of the graph is the first cycle, the second half of the graph is the second cycle, and you can see the placebo groups are getting worse, their EDSS is going up, but the treatment groups are getting better, and if you look closely, you can see the dotted line, the intrathecal group seems to have better results. And when they looked at confirmed disability progression, this means that your EDSS worsens, and then upon follow-up later on, it's still worse, so it wasn't just a minor relapse or temporary fluctuation. This confirmed disability progression occurred in only 6.7% of those getting intrathecal mesenchymal stem cells versus 41.9% in those who got placebo. An enormous difference, and it's highly statistically significant with a p-value of 0.0003. I'll note that this 41.9% confirmed disability progression figure is extremely high, much, much higher than what I would expect in a random cohort of people with progressive MS, but regardless, the results look good for intrathecal stem cells. In the same study, they looked at relapses depicted on the left and gadolinium-enhancing lesions. You can see the 3 columns: intrathecal mesenchymal stem cells, intravenous, and then placebo. Same thing for the gadolinium-enhancing lesions. And each little dot represents an event, either a relapse or a new lesion. And you can see there were far fewer relapses in those getting the intrathecal mesenchymal stem cells compared to placebo. And this was highly statistically significant with a p-value of less than 0.0005. Now, for enhancing lesions, it was not as clear. You can see there's a trend towards fewer enhancing lesions with the intrathecal treatment compared to placebo, but it was not statistically significant, a p-value of 0.062. For the intravenous treatment, there was no clear benefit over placebo. Here's another randomized trial done at the Tisch MS Center. Senior author Dr. Saad Sadiq, who's very well known for his stem cell research. I met him at a conference many years ago. Very interesting guy to talk to. They had 54 participants, 27 getting the treatment, 27 getting placebo, and these individuals subjected themselves to 6 spinal taps because they got 6 intrathecal injections of 10 million mesenchymal stem cell progenitors every 2 months. You have to give a ton of credit to the patients who enter these trials and further this research and contribute to the overall science and future generations of people with MS. Now, they had a problem with the blinding where the person injecting the stem cells was not blinded. They knew the treatment, but they kept the examining physician and the patient blinded, so hopefully everything was kosher. This was a 2-year study with a crossover design. After 1 year, those getting the placebo could then get the treatment, and their primary outcome was something called EDSS plus, where you could look for changes both in the EDSS, but also the timed 25-foot walk, how fast you can walk in 25 feet, and the 9-hole peg test, which is a measure of upper extremity function, where you have to put pegs into different holes as quickly as you can. And there was no benefit. 33% receiving the stem cells improved in this measure versus only 37% receiving saline. So the placebo group did slightly better, obviously not a statistically significant difference. They looked at many other measures, including the 6-minute walk test, how far you can walk in 6 minutes. That should be very sensitive to slight changes, but there was no difference. They looked at tests of cognitive function, the PACE-SAT I mentioned earlier. There was no difference. Now, they did some subgroup analysis, and they found possible benefits in people who had greater disability at baseline, who had an EDSS of 6 to 6.5 at baseline. They also showed some statistically significant improvements in bladder function, but overall, in my opinion, the study was unimpressive and basically negative. Here's a meta-analysis where they reviewed 11 randomized controlled trials. Now, not all of these were mesenchymal stem cell trials. They also included hematopoietic stem cells, and of course, there are technical differences with different mesenchymal stem cell products as well. There were 691 total participants, and they didn't find anything. There was a weak, non-statistically significant trend. The treatment group did do better on the EDSS score with a change compared to placebo of 0.35 lower, which is better, and there was no benefit in T2 lesions on MRI scans, though they found the treatment to be relatively safe with no obvious safety concerns. In general, the side effects that have been reported with mesenchymal stem cell treatments include headaches and even allergic reactions, including anaphylaxis, thrombophlebitis, or inflammation and clotting at the IV site. When giving intrathecal injections, there may be additional risk. There was a case report I found of a woman who 1 year after having the treatment developed cauda equina syndrome, or injury to the end of the spinal cord with enlargement of the nerve roots of the cauda equina on MRI scans. And this was done in a woman who had a prior stroke and macular degeneration and arthritis, and I found it to be very unusual that it occurred so far after the treatment, though of course it occurred very close to the area of injection, so I presume that it was in fact related. It's also been a theoretical concern that there could be a chance of developing a tumor if the stem cells could somehow differentiate into a tumor such as a teratoma, though it may be safer with mesenchymal stem cells, or if the cells could somehow obstruct the drainage of the cerebrospinal fluid and cause hydrocephalus or enlargement of the fluid-filled spaces in the brain, though I was unable to find a case report of that specific side effect. I'll end by giving my personal opinion, and I think the most ethical thing is to give you my honest and straightforward opinion, because I've seen people pursue proprietary stem cell treatments and be very disappointed with the results and sometimes spend tens of thousands of dollars, so I think I owe you my honest opinion, and I'm very, very skeptical of this treatment. I'm not exactly sure what the stem cells are supposed to do. Even if they could get to the site of injury, none of these studies have any particular manipulation of the cells that would make them more likely to actually differentiate into productive tissues. If we wanted cells to have an anti-inflammatory effect, frankly, I think we have drugs that are probably much better. For this treatment to work, I think the mesenchymal stem cells would have to differentiate into some sort of neural tissue and do something productive, whether it's remyelination or something else. I don't think any kind of anti-inflammatory or indirect neuroprotective effect is likely to be that effective. And I think we would have to see significant innovations and improvement in technology to really be able to program stem cells to do something specific, to really turn them into nano machines, and we don't seem to be quite there yet. In terms of the clinical trials, I think the open label trials are unimpressive. I've seen many ineffective treatments that have been completely disproven in randomized trials look good in open label unblinded trials. It's just not good enough. In terms of the randomized trial, really the one that sticks out at me is the Hadassah study. The intrathecal data is very impressive. However, I find it to be a little bit unusual that the placebo group did so incredibly badly. I didn't include a comparison to other randomized trials in progressive MS or relapsing MS, like for instance the OPERA or oratorio trial, but just take my word for it, that rate of confirmed disability progression is much worse than expected in the placebo group. I'm not trying to discredit them, but I'd like to see if that study could maybe be repeated by another group. One thing about medicine in general is there's no treatment that only one doctor or one medical center can do. Generally speaking, any surgery, any complicated drug regimen can be done and copied by multiple people, and that's why repetition in science is so important. I'd like to know your thoughts. Do you think I'm being excessively cynical? Do you think this treatment could work? Have you had this treatment? What were your results? And would you be interested in pursuing this treatment? And do you have suggestions for other videos? Again, please feel free to check out the citations below.